I think we'll give it another minute and then call the meeting to order.
Lorraine, I'm not sure if we're gonna have quorum, but we could probably get started.
Okay, thank you. Good afternoon. I'd like to call the April 28th, 2025 PDASC meeting to order at 2:02 p.m. Christina, can you please call the roll?
I can, thank you. Renee Bovell? Renee Bovell? Sean Brown?
I am here.
Thank you. Angela Bryant? Angela Bryant? Allison Siborowski? Allison Siborowski? Lorraine Diana?
Present.
Thank you. John Elliott? John Elliott? Candace Hall?
Here.
Thank you. Dr. Sharita Golden?
Present.
Thank you. Jim Gutman?
Present.
Thank you. Darren Johnson? Darren Johnson? Greta Kessler? Greta Kessler? Barry Lipsy? Barry Lipsy? Eric Morse?
Present.
Thank you. Mark Nicole? Mark Nicole? Sean O'Brien?
Present.
Thank you. Haley Park? Haley Park? Mandy Poplowski? Mandy Poplowski? Amy Prentice?
Present.
Thank you. Kimberly Robinson? Kimberly Robinson? Glenn Schneider? Glenn Schneider? Kelly Schultz? Kelly Schultz? Dr. Danita Tolson?
Present.
Thank you.
Mhm.
Sean Tunis?
Yep, I'm here.
Thank you. Joe Wynn? Joe Wynn? Thea Williams? Thea Williams? Co-Chair Diana, we currently do not have quorum, so we're gonna have to hold the meeting minutes. If we end up having quorum at the end of the meeting, you might be able to move it to then.
Okay, thank you, Christina. Let's move on. There's an opportunity for public comment. Christina, did we receive any public comments?
We received no written comments. We have one request for oral public comment. This person will have 1 minute and 30 seconds to speak. When I call on you, please state your name, the organization, agency, employer, or other entity in which you are affiliated, if any, or whether you're a consumer. And then the agenda item that you would like to address, and then you can start your comment. Let me make sure I can get the timer up. And I'm going to be calling on Derek Flowers from the Value of Care Coalition. Are you here?
I am.
Okay. Can you just state your organization and the agenda item, and then I will get the timer started, please.
Sure. I'm Derek Flowers from the Value of Care Coalition, and I guess I'm speaking about the administrative update and the assumption that that will include a legislative update from this session.
Okay, I'm starting the timer. You may begin. Thank you.
Well, good afternoon, and thanks for the opportunity to speak. As I mentioned, I'm Derek Flowers. I represent the Value of Care Coalition. We're a network of patient, healthcare provider, and caregiver organizations, and we're concerned about the unanswered questions and unintended consequences that might result from the PDASC upper payment limit decisions. We were encouraged that legislation passed this month allows for 2 more patient voices and 1 more clinician member on the Stakeholder Council. It's an important step towards broader, more inclusive representation. At the same time, we're concerned. The lack of collaboration between the board and the Stakeholder Council has become clear. Many in our community feel that direct patient and provider input is often disregarded as well, and that perception was reinforced at the PDASC meeting in March. During that meeting, we heard board comments favoring haste over rigor when discussing cost review reports and expediency over accountability when evaluating the impact of upper payment limits. We'll be following up with a letter directly to the board detailing those concerns, but I wanted to raise the issue today as well, given your advisory role to the PDASC. Respectfully, we urge you to help ensure that meaningful input and accountability stay central, not sidelined as the cost review process moves forward. Thank you very much.
Thank you.
Thank you. Christina, will you give us a quick administrative update, please?
Yes, I will. Just very quickly, the next board meeting will take place on May 19th, 2025 at 2:00 p.m. This meeting is going to be virtual. Information regarding registration and comments will be posted on the website soon. We wanted to give you a quick legislative update. House Bill 424, Senate Bill 357, Prescription Drug Affordability Board Authority and Stakeholder Council membership, lowering prescription drug costs for all Marylanders Now Act passed this legislative session. This legislation creates a process for the board to set upper payment limits for payers in Maryland after the board successfully implements upper payment limits for state and local government. It is also adding 3 new members to the PDASC starting July 1, 2025. We're going to have 1 representative from the rare disease community, 1 representative of oncologists, and 1 representative of a patient advocacy organization. Regarding appointments, staff has been made aware that staff has made all appointing offices aware of appointments that have expired and appointments that are vacant. Staff is not involved in the reappointment process, but I would like to thank everyone who's continuing to serve beyond their appointment expiration as we continue to work on reappointments and appointments. With that said, we do have 3 new members to the PDASC. I would like to introduce each of those members. I'm going to give them a quick minute to give a brief introduction about themselves. Dr. Danita Colson, she was appointed by the Senate President, she was appointed by Speaker Jones as the statewide organization for diverse communities representative, but she is also the president of the Baltimore County NAACP. She holds a doctorate of education and a bachelor's in nursing. And she also is very involved at Coppin State University's undergraduate nursing program. And she's also taught classes at Coppin as an assistant professor, as well as Johns Hopkins University and Bowie State University. Dr. Tolson, welcome to the PDASC. Would you like to tell us a little bit more about yourself?
Okay, I am the second vice president of the Maryland State Conference, NAACP. As you said, I am a registered nurse. I am a candidate for the family nurse practitioner. I also practice, my specialty is psych mental health. I also practice as a med-surg nurse also, as well as in the community with advocacy, speaking for my patients. You also talked about me being an assistant professor at Coppin State University. I'm actually an associate professor at Coppin State University. I also have taught at Maryland, University of Maryland. I know you said Johns Hopkins also, but the University of Maryland also, and many other things that I've done. So I am pleased to serve on the board.
Well, we are so pleased to have you here on the Stakeholder Council. And we're also pleased to have your clinical and all of your knowledge in nursing to help us make important, insightful advisory decisions here.
Mhm.
So thank you. Thank you so much.
Thank you.
Welcome.
Thank you.
Next, I would like to introduce Candace Hall. She's our pharmacologist representative, and she was appointed by the governor. She's a native of Maryland. She discovered her passion for science and health early on, and she's inspired by her mother's work as a physical therapist. She earned a bachelor's degree in psychology from the Catholic University of Maryland and began her career as a post-baccalaureate research fellow at the National Institute of Mental Health. She has a master's in psychology from American University, where her research at the Uniformed Services University focused on health disparities and promoting positive health behaviors among underserved populations. She has held clinical research roles at Inova Fairfax Hospital and Children's National Medical Center, and managed a portfolio of comparative effectiveness trials at the Patient-Centered Outcomes Research Institute, where she helped develop the $50 million Healthy Aging Initiative. Ms. Hall, would you like to say a few words about yourself? We're very excited to have you.
Sure. Thank you so much. I'm really excited to join the Stakeholder Council. I am also a PhD student at the University of Maryland, Baltimore at the School of Pharmacy. My research there focuses on patient-centered outcomes research and really incorporating the patient voice and stakeholder voices into impactful clinical trials. And I'm also interested in clinical outcomes assessment and ensuring that what the research question is asking, we have appropriate outcomes measuring what not only accurately captures the outcomes of the research question, but also what the patient is hoping to see out of the research trial. So happy to be here. I hope I can be a resource. Thank you for having me.
Great. Thank you. Thank you so much for joining us. We look forward to working with you.
Welcome.
And then lastly, I would like to introduce Amy Prentice. She was appointed by the governor as our brand name drug corporations representative. She's the director of corporate and state government affairs, home stake ecosystems at AstraZeneca, where she's responsible for shaping AstraZeneca's legislative and public policy on state healthcare issues in the Mid-Atlantic region. With more than 10 years of experience in the healthcare sector, she has consistently championed initiatives that drive meaningful change and improve patient access. Amy previously worked with the National Psoriasis Foundation and America's Health Insurance Plans. She has a master's in public administration from George Mason University. Amy, would you like to say a few words about yourself? Thank you. Thank you for joining us.
Yep. Hey, Christina, thank you for that introduction, and overview of my background. Just wanted to say, I appreciate the opportunity. I'm really happy to be here, and I look forward to working with everyone.
Great. Thank you.
Welcome.
Just a side note, Lorraine, I see three more people have joined. I don't know if you want me to do one more extra roll call, because that would give us quorum for the minutes, if you want to make a motion to.
That would be good, Christina.
Okay. Mandy Poplawski, are you here? Let's see, Mandy.
Present, sorry.
Thank,
Couldn't find my
thank you.
unmute.
No, that's okay. Haley Park,
Present.
thank you. Glenn Snyder,
I'm here. Thank you.
thank you. And then Kim Robinson,
Present.
co-chair Diana, we do have quorum now.
Thank you. Let's go ahead and move to approve the December 16, 2024 meeting minutes. So if you've all had a chance to look those over, first we need to have a motion to approve and as drafted. Do I have a motion?
So moved. O'Brien.
Thank you. And a second?
I'll second Jim Gutman.
Thank you. Any discussion? If no discussion, all who approve say aye.
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 All opposed say nay. There are no nays. The minutes are approved as drafted. Thank you. And so we'll move on now into our learning series and discussion on drug pricing and supply chain overview. I'm going to turn it over to Andrew York to introduce us to Dr. Ben Link from 3Axis Advisors, who will be presenting to the PDASC today. Andrew will also provide a little context on the presentation.
Great. Thanks, Chair Diana. So we are very excited to have the opportunity to use some of the stakeholder council sessions to work through a learning series and do a deeper dive on some of the topics that are going to be relevant for both the board and the stakeholder council. So we're kind of in between work for the stakeholder council. So while we have this time, we're certainly going to take advantage. And our first presentation is going to be to go through the complexity of the drug supply chain and give an overview of some of the key issues within drug pricing and the different metrics within drug pricing. So with that, we're very excited to introduce Dr. Ben Link. He works with 3Axis Advisors, which is the team that helped uncover some of the issues around spread pricing in 2010 and kind of made those issues famous. And then since then, they've continued to be at the cutting edge of a lot of this kind of quantitative and descriptive research on some of the features that we're seeing in the prescription drug supply chain. His Drug Pricing 101 podcast is required listening for all PDAB staff, as well as our stakeholder council members. I'm sure all the members on the line have listened to all probably 15 hours of the podcast. And he's also been an expert that's presented before both the Maryland legislature and also some other Maryland agencies. And with this presentation, this is what we were really trying to do with our prescription drug supply chain report that we put out. But he just does this much better than we do, kind of outlining the key stakeholders and then flagging some of the key issues and complexities of the supply chain. One quick note that I will add is that this is meant to be a reference. So it's going to be a pretty long meeting. It's a very substantial presentation. If folks need to drop off, this will be recorded and it will be posted on the website. So this is meant to be kind of a long-term reference on all of these complex issues, and this will be available after this meeting. If anyone does need to drop off, the recording will be available. And then also, I'll defer to Dr. Link, but I believe the presentation is kind of broken up into three broader sections, and I think we want to save questions for the breaks between those sessions. So I would say, please write your questions down. He can go back to different slides if you want to reference them, but I think we want to let him get through each section and then kind of group all the questions together. So with that, we are extremely excited to introduce Dr. Ben Link and also let him give a little bit more of an introduction on his background as well. Dr. Link, thanks for your time on this.
Thank you. And thank you to you and Christina for helping me behind the scenes get here. Thank you to the chair, the vice chair, members of this council and board for their interest in having me, and to the public writ large who has shown up to hear me talk. As way of some table setting, I think it's important to note at the outset that my presentation style is not one that's going to read the slides. I'm going to talk and the slides will hopefully match what I'm saying like it does now with this introduction. My name is Ben Link. I have taken on a moniker of the pharmacist fed up with fake artificially inflated drug pricing. And that largely has to do with my experience. I have known I wanted to be a pharmacist since I was in the 7th grade, when my mom had me interview all my relatives to find out what they did. And my aunt, who's a doctor, said if she could do it all over again, she'd develop drugs. And that's what got me interested in pharmacy. And I never really changed my mind. I thought I would be a retail pharmacist. I got a job at 18 being a technician. And, when I went to pharmacy school, quickly became an intern and then a retail pharmacist. Over the course of that experience, I had many opportunities to see what drug pricing in practice really looked like. And the moment that changed me was when I was at the retail pharmacy and a lady came in for her cancer med, her chemotherapy nausea medication ondansetron, recently gone generic. And the insurance restricted the number of pills that she could get, and they were too expensive for her. And trying to call around to find other pharmacies that had it, the pharmacy that I ultimately transferred the script to, because they were much more affordable than mine, berated me for the price at my pharmacy, even though I was working for a chain at the time and had no control over that drug's price. But that ultimately started me down the road that led me to having a job which is largely based upon studying drug prices, which isn't something they taught you in pharmacy school, was a thing you could actually do. So at the start of this presentation, I think it's important to note that over the course of the work I've done, I have worked with effectively all levels of the drug supply chain that we are likely going to talk about today, or at least that I have planned to talk about. I've worked for government agencies, either directly or as a vendor. I have worked to consult with professional organizations, including pharmacy groups. I have worked with pharmacies themselves or buying groups or those that are interested in potentially selling things to pharmacy. Most relevant in the disclosures that I think I could make today are that I am planning on discussing the Mark Cuban Cost Plus Drug Company, which is a current consulting client of 3-Axis Advisors. So with that said, I have 3 broad goals over what I hope to accomplish during this presentation today, which is try to talk about what drug prices actually mean when we talk about them, do a little bit of history lesson that explains hopefully why we got to where we're at with our crazy drug pricing world. I'll try to review how those prices get used in contracts to the extent that we have public information that I can highlight to do that. And then at the end, I will try to give examples of how drug pricing gets used in actual practice and how sometimes it falls outside even all of these pricing benchmarks that we're going to talk about. As was stated, this is broken up into 3 large sections. We will spend the majority of our time on section 1. I will pause after each of these sections to see if you have any questions. With a group this large, I would, otherwise in a normal smaller group, I take presentations or questions as they come during the presentation. But with a group this size, I think it's best to have pre-planned stops and to just give my voice a break as well. So it's also important to note at the onset in terms of table setting that I am a presenter that learns best by understanding the history of how we got here. I'm very much a history buff. I was the kind of kid who would come home from high school and turn on the History Channel, not the ESPN Sports. That said, I recognize that not everyone finds history that interesting or connects with it that well. While I've done my best to try to present this information in a logical manner to ease comprehension, I think that you as the audience have, equal stake in the success of this presentation as I do. And I'd very much encourage you to ask any sort of questions that you may have for clarity, because I assure you somebody else is likely having them as well. And though I've given my best ability to try to make this comprehensive, the best way to ensure comprehension is if you ask whatever questions you may have. So without any further ado, let's get started. So when I thought about how to start about the conversation of drug pricing, I thought about trying to find the most earliest reference to drug pricing that I could find. And it turns out that depending upon your point of view of what is or isn't a drug, there is historical evidence to suggest that we've potentially always had drug prices for as long as there's been recipes or formulas or herbs or whatever you want to call them, nutraceuticals, medicinal herbs, whatever term you want to use, there has been a value associated with them, a monetary thing that we could potentially exchange to receive those services. And so we have ancient papyrus from Egypt, we have Babylonian cuneiform tablets that speak to a history of trying to treat various ailments and costs potentially associated with those various forms of treatment. I say this not to have an overwhelming history at the start, but just to point out that the interest in drug prices is one that we have had for thousands of years. And so it's perhaps helpful to have the context that if we're still figuring out drug prices, perhaps that's not too dissimilar from what we've been trying to do for effectively a very long time. Bringing the tape forward many thousands of years, I highlight that the first kind of recipe book that we had was a group of 11 docs getting together in 1820 to establish the pharmacopoeia. Before we had things like the Food and Drug Administration or regulations about what could and couldn't be sold, there was a problem with a lack of standards. If I wanted to treat your burn, how do I tell the pharmacist, the chemist, to compound the right kind of ointment to assuage your pain with your burn? A pharmacopoeia is effectively a recipe book, a way of creating a standard around what those drugs look like. It makes the practice of medicine easier. And so now that we have standards around kind of the concoctions that we could use, we can start to have more perhaps standardized prices. If you charge one price to provide this preparation, someone else in time might charge a different price for whatever reason. What changed is that we had conflict. The Mexican-American War of the mid-1800s was one where, though many people died in association with the conflict, the majority of those deaths weren't associated with combat injuries. It was actually determined that things like tainted food and medicine were a cause of a great deal more deaths than combat. And that led to our first drug laws in this country, which is the Drug Importation Act, following the Mexican-American War. And the point here being is that before we cared about anything else in drug prices, we arguably cared about safety. And this becomes apparent when you see things like the Uptown St. Clair, the Jungle publication about the meatpacking industry. In 1906, we get to the point where we care enough about safety to try to enact federal requirements across the states, not just bringing things into the states, but across how things are handled at the state level to ensure that effectively the drugs we're taking and relying upon to treat our health is safe. What's interesting is that there was a Supreme Court case very soon after this law was passed that said while this act might care about safety, there is nothing within the Food Drug Act that prohibits false therapeutic claims or false or misleading statements. Only that the label must clearly distinguish what's actually in it. And so a few decades later, we finally get through things like the elixir sulfonamide scandal, which is a safety concern, and the thalidomide scandal, which is also a safety concern. We get to the point where we have the Food, Drug, and Cosmetic Act saying that not only do we care about safe drugs, but we care that they be proven safe before they get marketed in our country. And then after that, by 1960s, we say that not only do we care that they're proven safe before they're marketed, but they're proven effective before we're marketed. So the point of this little history tangent is to prove that for 140 years, largely, we had drug prices that were transacted based upon what I was willing to buy versus what you were willing to sell. And over time, as we cared more about what we were actually buying and selling, i.e. safe and effective drugs, the regulations on what we cared about with drugs is going to influence how we perceive and value the price of those drugs. And perhaps nothing demonstrates that more when we try to bring in the insurance angle to this. So why did we move from a system where the patient was effectively fully responsible for their drug cost to one where we started to have third parties involved in drug costs? Well, the World War II and the Korean conflict created a situation where there was a lot of competition for labor here at home. And one of the approaches legislatively at the time to deal with that competition over wages was to pass a stabilization act. Basically, the idea that wages will be fixed. If you want to hire a glass blower, you pay the glass blower wage. You don't necessarily compete by raising that wage to do that. And so that gave rise to the idea, well, if I can't raise your payment, maybe I can offer fringe benefits. Things like paying your hospital bill for the baby you might have, or helping you buy those drugs. For a long time, drugs were the fringes of fringe healthcare benefits. They weren't viewed as that important because they were largely still very affordable to patients just directly. A hospital bill was more of the money than the medication was, and that's still largely true today. But as we started to care more about ensuring safe drugs before we take them and ensuring that they do what they promise to do before we take them, the cost of the drug started to rise and people started to associate more of a benefit from getting support in covering those costs than they had previously attributed. It got to the point where in the late 1960s, you get the United Autos Workers Union saying that we actually want a benefit card. We want to be able to receive the value of our prescription drug coverage more acutely, more on demand in real time. This isn't real-time claim transactions yet. This is still too early in our conversation to talk about that. But what it was is this idea that beforehand, if I had prescription drug coverage, I still paid the claim out of my own pocket. They just potentially collected in a shoebox, as they were called shoebox claims. And I would wait until that box was worth my time of filling all the paperwork out to try to get the value of my coverage back. The card plans were this idea that no, we can actually say because your name is on this benefit card, you can just pay a flat fee at the pharmacy and then we will help pay for the claim afterwards or when that gets submitted to us. You don't have to handle the paperwork as much. So in essence, my very brief history of 1,000 years of drug pricing is trying to convey that we went from a system where the product and financial flow was very direct. Somebody made it, somebody potentially moved it to a more convenient place to sell it, and they sold it to people, and the money flew back up so that they could buy and sell more things, to one where arguably the most famous image that I'm sure you've seen many times is this very complicated movement of not only just product, but money and contract relationships. So while the product still goes largely from the manufacturer to the wholesaler, to the pharmacy, to the patient, one additional step from what we just reviewed, we have a lot of different changes of dollars in this system today, a lot of different relationships that we have to consider and keep in mind when we talk about drug pricing, because by and large, the drug prices we're going to talk about are designed to contextualize some aspect of this system, but in so doing, they are not the full, perhaps, contextualization that we might think or want them to be. So arguably, a lot of our healthcare policy over the last several decades has been focused on increasing the number of people that have access to insurance. We know from surveys today that these policies have perhaps been successful because more people have healthcare insurance today than in years prior. Certainly in years prior to the Affordable Care Act, individual years may fluctuate slightly on whether that's the truth. As a pharmacy, when you see stats like this, what this is saying is that insurance is going to largely dominate the perception on drug prices because you're going to be selling to people primarily through their insurance, not directly. So this is the first kind of bifurcation or where some of our parallels to other forms of retail transactions don't work. While card plans, PBMs, intermediaries might have started like a traditional Visa and MasterCard, just kind of transacting the money, moving the money between parties without really a say in the value of those dollars. We've gotten to a point today where almost no transactions in the pharmacy space occur outside of an insurance company being involved in that transaction. And as we'll see, unlike, say, a Visa or MasterCard, which just moves the money around, the insurance industry today has a large role to potentially say in shaping some of our perceptions about drug prices through their use of discounts off of those prices. Data also tells us that from an incentive point of view, the majority of dollars in this healthcare transaction on an individual basis are coming from the third party payer, not the patient's cost directly. So when you see a $10 charge at the pharmacy counter to pick up your prescription, chances are good that your insurance paid $90 or more outside of that to help you actually be able to take that prescription from the pharmacy. We know that this space is dominated by a few number of very large players. So when we think about how the system works today, there are three primary players, Optum, Express Scripts, and Caremark, that have a large role in the transaction process that we're going to spend so much time talking about. So I did look at your backgrounds in advance of this meeting, and I believe that this next section I can fly through, but we can revisit it if your questions require. But just for the sake of completeness, I wanted to be sure that we spent at least a second to put the players on the board very specifically. So when we think about drug manufacturers are relegated or regulated at both the federal and state level. They have laws that they have to apply to, and even potentially international laws that they have to apply to. This is and a lot of this is going to reflect my home state. I'm from Ohio. This is the Ohio revised codes definition of if you do this, if you act like this kind of business in the state of Ohio, other things apply to you that don't if you are a manufacturer of cell phone cases or steel beams or whatever else. We care enough about safety and efficacy and the public's trust in the system that there are additional rules if you act like a manufacturer. Next to the manufacturer are wholesalers. There are hundreds of drug manufacturing companies out there today. Rather than a pharmacy or a patient have to go get their diabetes drug at one place and their cholesterol drug at another, a wholesaler consolidates that shopping experience. So instead of going to like the Kraft cheese store to get cheese and the General Mills to get your cereal, a wholesaler lets us consolidate all of our purchases in one spot for more efficient delivery. Before we could get Amazon to ship us things in 2 days, a wholesaler could take a cold shipped like insulin product and deliver it next day to a pharmacy in this country. Pharmacies are the providers that we know. They are the retail pharmacies by and large that are at the corner of our neighborhoods to help us get the medicines that we need. But over time, pharmacies themselves have also evolved. Pharmacies are no longer just these chemists compounding things. They can also be specialty, mail order, closed door facility, infusion clinics that deal with very complicated medicines to try to get them to people when they need them. I also want to be sure that we briefly mention that to connect this system together of health plans helping patients buy drugs, pharmacy providers, drug manufacturers, we have these intermediaries known as pharmacy benefit managers. PBMs are the middlemen in our current drug supply chain overview that are connected most acutely to the most spots. If we go back to this earlier image, we can see that the one who has the most connections on the board is by and large the PBM. We then have the health plan, the person who has taken on the role of helping to pay for the patient's drugs. This can be your employer, this can be a government program, this could be a potential charity if they've set up themselves as a way to provide health benefits. And then finally, we are all patients in the system. We're all the end consumers. When we need our sore throat treated or our cancer addressed or our blood pressure controlled, we receive the benefits of our complicated system to the extent that we can. It's important that we recognize that over time, this system, which, still seems maybe like it's kind of direct in a way, has become incredibly complicated because we're in an era now where it's possible that every step along the healthcare transaction is controlled by a single vertical, meaning that I might see my insurer's doctor, go to my insurer's pharmacy, use my insurance card to receive my drug. And that drug might have been distributed to the pharmacy through an arrangement that was more or less controlled and regulated by that same insurer. So with that brief background out of the way, let's start talking about the meats and potatoes of why I believe I'm here today, which is talk about what is drug pricing in the United States as we can perhaps best try to understand it. To start, I want to say that oftentimes when we talk about price, we have perhaps some existing points of view that might influence our perception of price. When we think of things like stocks or gasoline or whatever it is, there is a prevailing belief that there is an efficient marketplace, meaning that so long as there's enough information between buyers and sellers, market-driven pricing can prevail. If you were buying a stock today, you wouldn't care or wouldn't think that you needed to care which platform you used to do it, whether that was Charles Schwab, Fidelity, whatever it is. You believe that you would reasonably know that you're getting the same access to that stock at the same price as you would wherever you went. Similarly with gas prices, I might see that this gas price is higher than the one down the street, but at least I see it. I know to expect it. If I pull into that station and start to fill up my car, I would expect to potentially pay more because of the price transparency given to me before I made the decision to purchase. In other words, we largely believe that through transparency in an efficient marketplace, we can get prices that we feel comfortable with, are trustworthy in the regulatory system that we've designed to manage commerce in this country. When it comes to drug pricing, one of the first things that I learned in this space was that it can be easy to think you're talking about a drug's price in a certain way, but then not communicating about that drug price in the way that you think you are, the person not hearing the drug price under the same understanding. The easiest example of this is, what is the manufacturer's drug price? We often hear stories about the manufacturer's drug price. Oftentimes, what is not said explicitly in that conversation is that we're talking about the wholesale acquisition cost, or the WAC price for that drug. But there are other ways to contextualize a drug manufacturer's price. NADAC and AWP, some of the more common ways that same drug manufacturer's price might be contextualized, and they potentially tell us very different things about that price. And so if we think we're talking about things in an AWP price, but we're actually talking about them in a NADAC world, we could be magnitudes off on what we mean when we talk about drug pricing. And as we see, a lot of this comes down to that our drug prices are by and large hidden and set by contracts. If you listen to testimony by whomever on the drug channel goes before Congress to talk about drug prices, oftentimes a common theme is that, well, we cannot disclose or we cannot publish our prices because to do so would put us at a competitive disadvantage. If others could see what we were doing, we would lose our leverage in our contract negotiations and wouldn't help you get the best, lowest price. And there can absolutely be truth to that. But what happens with our equation when they are hidden and set by contracts is it also means that we can have contract loopholes or other sorts of exploitation that manipulate the prices we experience, and we don't experience them in the way that we thought we were going to experience them, regardless of which drug pricing benchmark we're talking about. So how do we establish drug prices, any of these various paradigms, in the United States? Well, the primary way that that is effectuated is through publishers of drug pricing data. There are groups out there whose job it is to provide access to insights on what a drug's price is. You can get some of them from the federal government directly through public websites like CMS publishes NADAC. But the majority of the ones that get used in contract or that are interested in for other reasons, because say a rebate is a percentage of that drug's price, those are paywalled. You have to have access to a subscription service like First Data Bank or Medispan or Gold Standard to get the AWP, the WAC price information that you might otherwise seek to use to contextualize the drug price. So we're going to go through a large number of the drug prices on this layout today. So I talked about this image already from drug channels. We're now going to try to map where the various drug pricing benchmarks fit in the supply chain relative to that worldview. And we're going to start with the oldest and arguably the most impactful to our system, which is average wholesale price, AWP, also sometimes referred to as ain't what paid, but that isn't always or wasn't always the case. So when we think about AWP, what we should recognize is that AWP is not a price that is defined in federal statute. Most of the other prices we're going to talk about today have a current definition in the law somewhere that tells us what it is and what it means. AWP does not have that. What AWP means is largely what whomever publishes it or whoever gave it to the publisher is suggesting it means, and those definitions can vary. The origin of AWP aligns with our narrative around after we stopped caring about ensuring that drugs were safe and effective because we had passed that legislation shortly thereafter. Well, now there's this vested interest in paying for these drugs, right? You had a California Medicaid pharmacist named George Pennebaker going around the state of California saying, hey, it would be great if instead of just relying on providers to, send in their bills or whatever, if we could be more proactive, if there was kind of a standard price, perhaps an average wholesale price that we could use to pay for their drugs. And so if they said, I bought whatever drug it was at the time, I just say, well, I know what the AWP for that, and I will just pay you that rather than you having to tell me that cost. And the way that pricing was largely communicated back then was through publications like this, Redbook. This is the 1968 edition of Redbook. And it has in it just drug names and their reported prices. And if you look into this thing, it basically says that the second column shows the price to the retail druggist. It is usually the wholesale price per dozen to the retailer. It can be an average, whatever. Because George Pennebaker, maybe, was going around asking about average wholesale price, the 1969 edition, the year after this, started to refer to two columns of pricing data. They had still their prices to customers or whatever, and then they had this average wholesale price. And that became largely what people gravitated to use for it. It became the predominant basis for the next approximately 2 decades for how we're going to pay for drugs in the United States. Now, again, this is from the public website of Wolters Kluwer, which is the publisher of Medispan, right? And they're telling us that despite its name, AWP doesn't represent an average of anything. That's a little bit different, perhaps, from its origin, right? This is the 1968 edition being fully clear. But the origin was an idea of a price that was reflective of something that is real, transactional, tangible. But it would later turn out that that wasn't really what we were getting. And so the important learning here is that drug prices can change over time. What we think they mean doesn't have to always be what they mean. After Redbook published AWP pricing in 1969, the year later, Blue Book started publishing pricing information, referring to it first as suggested wholesale price, but then later adopting the same moniker of average wholesale price. Effectively 5 years after we started all using this AWP or gravitating to using this AWP-based pricing benchmark, what we found out is investigations by the Department of Health, Education, and Welfare at the time determined that the Red Book, Blue Book, AWP, and other standard prices in the industry were frequently in excess of the actual acquisition cost. A 1977 report would find effectively the same thing, that the federal government was not convinced that basing drug costs in this AWP value was reflective of any sort of true measure of cost. In 1984, the Office of the Inspector General gets involved, releases an AWP report which says, hey, we looked at the published price and what pharmacists' actual acquisition cost was, and we found effectively a 16% difference in the aggregate, but sometimes it's as high as 42% off, effectively half wrong in our perception of price. For whatever reason, this same report was basically replicated in 1989, saying, yep, we got it right the first time. There is this disparity in drug prices. And these reports were largely commissioned before we gave a lot of credence to different types of drugs. So part of the reason, what's unsaid in the overall discount is 16, but there are some extreme up to 42, is there a difference between whether the drug is brand and generic in terms of how AWP is reacting to or publishing the price. Ultimately, this accumulates in enough interest that the federal government says, Medicaid, if you want us to help pay for drugs, we can no longer help you pay for drugs in a way that is 100% based on AWP. You must give us some other basis rather than paying 100% of AWP, whether that's a new price that you create or a discount off that price. We're going to do something else to determine drug cost. And as interest in drug pricing grew through the 90s into the early and mid 2000s, there were lawsuits related to drug manufacturer and intermediary actions related to AWP. It doesn't take a rocket scientist at a manufacturer to say, well, if they're going to be reimbursed by AWP, if I list a really high AWP and then sell it to the provider really low, the provider will want to use my drug. They'll perhaps be interested in selling more of my drug because they'll make bigger spreads off of it. And so the origin of some of our other pricing benchmark came from these lawsuits, these investigations that said, we see problems with AWP. There needs to do something else in regards to trying to understand drug prices. Now, despite everything I'm going to say, I want to preface that still the predominant way that pharmacy contracts are managed in the United States, where you're talking about contracts between pharmacies and insurers or insurers and third parties like health plans, they largely are predicated around AWP-based discounts. So even though this pricing benchmark has this historical challenges with it, it is still the predominant way with which we understand or express prices in our contracts, which is itself a very interesting observation. Now, for those who are not familiar as familiar with these, understand that historically or sometimes there is a perceived relationship between benchmark prices in a standard way that perhaps doesn't exist. As a result of some of these lawsuits, many people stopped publishing AWP, and by people I mean drug manufacturers, saying, I'm not going to put an AWP price out there. But because of its importance in contracts or otherwise, AWP prices still potentially get created for drugs, even if they're not published by the manufacturer. The pricing sources of Medispan, First Data Bank, whomever, they have editorial policies that say, if you don't provide us with all the information, we may extrapolate or otherwise publish a value just so that it's there when it's needed. And so we can see the effect of this if we actually study the relationship between where our drug prices are coming from. Generic drugs, by and large, still, those are drugs that are considered marketed under an abbreviated new drug application in ANDA. They, by and large, are still providing an AWP price to the compendia, versus things that we would generally consider brand drugs, biologics, or new drug applications. They're generally not providing an AWP price point. You can also see that the relationship between AWP and WAC, one of the benchmarks we'll talk about here in a sec, is not standard across this paradigm, whether we're looking at average for median relationships, what we see is that there is a discrepancy. This again speaks to some of that historic history we saw in the first AWP investigations, right? There is differences between what a brand drug does and walks and talks in the space than what generic drugs do. But that difference isn't always perhaps what we expect it to be, because I've done work at 46 Brooklyn that's demonstrated that if you look at what happens on an AWP basis to generic drugs that come into the market after brand drugs have been on the market, they by and large set their AWP price in a way that is apparently or seems to be close to the product they're replacing. So even though we had an exclusive patented whatever medicine that was this brand, when the generic comes onto the market, that first generic that's introduced, it looks a lot more like a brand than perhaps we think it would, at least on an AWP basis. The AWP price and the brand price are largely the same when we're looking at it through this lens. And if this is a little complicated, let me give you a real world example. Here is the price history for generic Nexium over a 5-year span. There was an AWP price that was on average at the beginning of 2015. And over time, rather than that AWP price go down on the aggregate, it went up. So even though more and more manufacturers started to produce generic Nexium, the underlying AWP price for those various products was higher as competition increased. Other pricing benchmarks, WAC, NADIC, ones we'll get to, they got lower, but not AWP. If you think about what we see in the contractual relationships, which again we'll talk about a little bit later, in the drug supply chain as it relates to generic drug prices in particular, it would be akin to trying to buy a current truck at $1 million or $1.5 million and saying, don't worry, significant other who is concerned with this purchase I'm about to make, I'm not going to get ripped off. I've negotiated a really good discount. I'm going to get 80% off the sticker price of this truck. That's what drug pricing from a certain point of view is telling us is how it's experienced today, at least through the lens, perhaps, of AWP. It's also important to distinguish when we talk about AWP that in large ways, because of that those lawsuits in the middle of the 2000s, sometimes AWP and another pricing benchmark, SWP, get conflated. One of the things that happened during those lawsuits, as on my slide previously, was that one of the publishers of these pricing benchmarks, First Data Bank, said, we will no longer publish AWP in regards to this. What we'll do instead is we'll publish this suggested wholesale price. Now, if you look at the definition of suggested wholesale price and average wholesale price, there are, in my opinion, a decent amount of similarities between those 2 points. Are they the exact same? No, but they seem to walk and talk and do very similar things. But if you're saying, I know the AWP price of a drug because I got it from First Data Bank, chances are you didn't actually get an AWP price from First Data Bank. You got an SWP price from First Data Bank. And so to try to put into context the value that we see in these drug pricing benchmarks, I chose a couple of interesting tidbits from publicly traded companies in our drug supply chain about what they say about drug pricing benchmarks. Now, this is not intended to be financial advice. I'm a pharmacist, not accountant, and these are totally tidbits. They're not fully contextualized within the broader 10K, so caveat imperator. But what I see when I look at these 10Ks is I see advice from pharmacies, from wholesalers, from insurers that say if things change with the way that we price drugs, if things change with these benchmarks used to establish pricing for prescription drugs, our ability to provide financial returns to you investors is potentially at risk, which is perhaps a good sign that we ought to care and give credence to what these benchmarks do and mean. I also highlighted earlier how AWP lacks a federal definition. So what you can see in publicly available pricing benchmarks, such as this one from the city of Mesa in Arizona, one of the first terms that has to be defined in your contract is what is average wholesale price? What does it mean? And how do I know what it means? Because I cannot necessarily have a base assured understanding of that because it's not defined. So that is AWP. We will revisit AWP more because we have to talk about it when we talk about its use in contracts. But we're going to shift to talk about some of the other benchmarks and do so hopefully quickly. We're going to talk about ASP. I talked about how in the settlements, say with the Bayer one, that manufacturers started to disclose as part of their settlements a great deal of information about their net prices as a way to try to deal with whatever the consequences of their actions were in those lawsuits. Eventually, it became a benchmark. There was enough interest in that type of access to information that I was like, hey, this is good enough. This worked well, perhaps from a point of view of that settlement, that we ought to start to use this as a real price in our drug supply chain. ASP, though, is a very interesting price because it has a very narrow application to our drug supply chain. It is really for provider-administered drugs and largely from the point of view of Medicare Part B. So Medicare was enacted in the late 60s, right around that, or in the mid 60s, right around the time when our drug pricing story really begins. And from the very beginning, even though Medicare didn't have a prescription drug program, a standalone thing for outpatient drugs, Medicare had to cover drug costs, things associated with hospital visits or whatever have you, but also because very shortly after the passage, they added coverage for end-stage renal disease, and they needed to cover the cost associated with those drugs. And much like the rest of the supply chain, they relied upon AWP to pay for those drug costs by and large until such time as they could get away from it. It took many decades for eventually enough to be learned both about operating Medicare and paying clinicians at the clinic to give these drugs, and enough about drug prices to get to a point where AWP wasn't working to pay for Medicare drugs in the provider setting anymore. Today, the definition of ASP is slightly different than what it was, or what it was initially perhaps conceived of. As you can see that it's got a on or effective date in its definition, and its definition is broken out by what does it mean and how is it calculated for brand drugs, and what does it mean and how does it calculated for generic drugs. A lot of this has to do with, on a brand basis, there's one guy making it, and on a generic basis, there are potentially a dozen different folks making that drug that we have to consider how they're going to influence the pricing benchmark. But regardless of how it gets calculated, the way it gets used is Medicare pays based upon ASP, but unlike today where we're discounting AWP to get drug prices, in Medicare, we're using a markup percentage to get those drug prices. We pay 100% and 106% or 6% above ASP to the providers for the purposes of this drug reimbursement. Now, CMS recognized that not all providers are the same, and CMS has tried to change ASP-based reimbursement for a subset of providers, specifically 340B hospitals, from a markup of ASP to a reduction of ASP based upon perceptions on how cheap it is for those groups to get the drugs themselves. Ultimately, it was found that what CMS attempted to do wasn't legal, and that has since been reversed, and they actually had to make one-time lump sum payments to make up for the time when they were reimbursing low. ASP pricing in a quick nutshell. WAC and direct price. WAC and direct price are defined in federal statute, unlike AWP, and they're by and large what we think we mean of when we talk about brand name drug prices. That's typically the underlying context that's not directly said. Now, WAC as a concept is a price that has changed over time. In a 1994 article about drug pricings, you can see that the definition of WAC and what WAC represents is not the one that aligns with our current federal statute. So again, what a price means and what it is perceived to mean can change over time, and we need to keep that in mind as we use these drug prices. The source of these is the second oldest price. This is a slide that probably should have been with the AWP one, so I apologize for it not being there. But the source of WAC is the same as the source of AWP. Our red book and blue book first started it, but it has since become something that is predominantly published by First Data Bank, by Medispan. Medispan and First Data Bank in large part are the companies that inherited these benchmarks. Blue Book is a First Data Bank parent company product. You can see what First Data Bank says WAC means in their editorial policy. It is the list price supplied by the manufacturer based upon how they intend to sell their product to wholesalers, but it's not transactional and it doesn't reflect discounts, rebates, or other price concessions that we know get baked into the system. Similarly, Medispan's price is a price that we know has a list price aspect to it. There is a price between the manufacturer and the wholesaler for the purposes of listing drugs, but not necessarily the actual price that drugs are bought at. If you look at what the federal government investigations or the CBO has said about these drug prices, we can see again that the relationship between brands WAC and generic WAC is not the same. There is a more of a fixed relationship between brand prices and how they're actually paid for and acquired by, say, pharmacies than there is for generics. A generic having a price, MSRP, if you will, between the manufacturer and the wholesaler does not necessarily translate in as well into what that pharmacy can expect to buy it for, like it does with the brand. As a more or less direct parallel to WAC is direct price. Direct price is not the price between the manufacturer and the wholesaler, but the price between the manufacturer and the provider who is buying it directly, the non-wholesalers. So just as quick pause, we have seen AWP, ASP, WAC, and direct price. We've largely talked about drug prices from the point of view of the manufacturer. We're going to now talk about drug prices from the point of view of the provider and then finish up with the third-party payers and then take questions. So we have just a few more to get through. I know it's a lot. I apologize. There's not a better way to break it up. When we talk about the closest approximation between the stepping stone between a manufacturer's price and a provider's price, the next most logical benchmark to talk about in my mind is average manufacturer price. Average manufacturer price has a federal statute that defines what it is, and it was created to help pay for rebates in the Medicaid program as part of OBRA 90. It has a federal definition under the statute that tells us how we're going to administer effectively a component of our Medicaid pricing. What's interesting is that as legislation was being considered for how Medicaid was going to handle drug prices, what was theoretically on the board or being advised was perhaps negotiating directly with manufacturers for prices or establishing state-specific lists for drug prices. I highlight this just to show that the things that we still consider and debate are things that we have perhaps considered and debated in the past. When we think about why the United States program seems to be, or the country seems largely to be predicated off of a high list price that is discounted or rebated down afterwards, we had an opportunity perhaps in the 90s to choose a different path to do things that other countries did with negotiating with manufacturers for price. And we have changed some of the restrictions on that, as we'll talk about when we talk about Medicare negotiated price. Why I say AMP is a good stepping stone between manufacturer list prices and provider list prices is because it is supposed to represent the net sale price between the manufacturer and the provider for retail pharmacies. If you think about when this was being created in the 90s, the things that were most expensive at the time were inhalers or cholesterol meds or insulin, things that we generally consider to be retail drugs. At the time, there were 8 listed exemptions to what was going to go into AMP. We today have 30 listed exemptions into what goes into AMP. The point being that anything that potentially messes with AMP messes with Medicaid's rebate. So while AMP is not a benchmark that is predominantly used to transact prices, it is a benchmark used to effectuate a net price experience, a discount off of them. So what the rules of the road today say is that for brand drugs, the manufacturer is responsible to pay a rebate of 23% off of AMP, or almost a quarter of the drug's price comes back to the federal government and the states after it's sold in the form of a brand rebate. There is some exceptions. There are specific drug types where that percentage are lower, and there's also a requirement that if somebody else got a better price than what the formula of 23% would produce, they have to get that as well. So if somebody convince a manufacturer to give them a price that is better than a quarter off, the government gets it kind of by default. There's also a component where they have to pay a penalty if the price rises faster than inflation. So if we're not going to negotiate drug prices with manufacturers, we can create an incentive or a financial consequence if they raise prices faster than inflation. Medicaid also gets rebates on generic drugs. 13% of the average manufacturer price comes back to the government in the form of a generic rebate, something that is more or less unique to Medicaid. Almost no other payers get generic-based rebates, but Medicaid does. So just for completeness sake, I highlighted that while AMP is the price that is used based upon this fancy calculation on what sales look like in the retail community setting, we also alongside need to recognize another drug pricing benchmark, best price, which is that manufacturer's lower price. If somebody did it better than what the default formula is, the benefits accrue to the government automatically. And again, this is an important consideration when we think of there is consolidation, not just at the insurer level, but also at the wholesaler level. The ability to determine what is and isn't a retail drug potentially determines how much supply is made accessible at the community pharmacy versus at a closed door mail or specialty pharmacy. This is actually a problem that the government ran into. They have special designation for a subset of drugs known as the 5I drugs, which is if you're an inhalation, an infusion, an implant device, things that start with I, we know that you typically don't get dispensed through the retail pharmacy channel due to perhaps your more complicated way of administering to the patient. And so we have a standard that says if you have 70% of or more of your sales to somebody other than a retail pharmacy, you can calculate your AMP and do things with your AMP in slightly different ways than the default way. And that can be advantageous to manufacturers to take advantage of. We also know that in this complicated way of dealing with this formula, it very much matters how drugs are sold because manufacturers sometimes sell a copy of themselves that would otherwise be a brand drug, but because of their marketing or labeling or whatever, it looks and acts a lot more like a generic drug. So authorized generics are something that had to be addressed with AMP-based pricing. So manufacturers can't just sell copies of themselves to other intermediaries as a way to potentially lower their prices. Because if you think about a formula where your rebate is a percentage of the AMP, the lower the AMP, the lower my rebate. So if I can eject a bunch of sales that look like generic drugs, not brands, which are generally cheaper, I can potentially pay less rebate. So this is something that had to be addressed. And if you think about what calculating this system actually means, where you have to not only know how you sell to wholesalers and at what price, but you got to monitor how wholesalers are then selling or distributing your drug across a pharmacy landscape that is increasingly less retail due to things like pharmacy closures from CVS, Walgreens, etc. Well, there's also allowances within the calculation for smoothing. There's a way for manufacturers to take historical experience and influence their current AMP price. AMP is only published on a quarterly basis. Without smoothing, you can potentially have big swings in price based upon what happened quarter over quarter. I highlight these things just to show that even in a very regulated and deliberate approach to what we want drug pricing to do, we're going to not negotiate directly for prices in the Medicaid program that was decision made legislatively. We're going to set up a system, a formula that says you're going to give us a certain price concession. And if somebody does better, you'll give it to us automatically. And we're going to create a disincentive for you to raise prices, hopefully. Then you can still have things arise from very deliberate approaches to drug pricing, things that you don't anticipate or necessarily expect because of the complexity around the way that drugs are used and administered and distributed in this country. So AMP represents a net price experience between the wholesaler and the manufacturer. NADAC and AACs are benchmarks designed to represent a kind of net price to pharmacies. And I caveat imperator at the very beginning, net price to pharmacies. NADAC is defined in statute. Again, this is a drug price that we know means something, and it's supposed to represent what pharmacies pay to buy drugs from their wholesaler. A lot of times we would think that that would be perhaps the end of the pricing discussion, but it's important to recognize, as we saw in our earlier image, that money between pharmacies and wholesalers potentially goes both ways, meaning it's possible that pharmacies receive discounts or credits or what is known as off-invoice discounts that don't mean that this reflects the true net price to pharmacy. It may be inflated to a degree. The origins of NADAC actually mirror the origin of AWP. I already talked about AWP, so if we go just past those AWP lawsuits of the mid-2000s, what started to happen is an interest in what does a future post-AWP look like. And there was actually a group of Medicaid directors that got together and wrote a white paper on wouldn't it be great if drug pricing acted this way as opposed to the way it currently does. And what they largely say is, wouldn't it be great if since the beginning of our AWP experience, when we saw that there was a disconnect between what pharmacies were actually buying at and what AWP was representing it, wouldn't it be great if we could get a more real experience of what pharmacies were actually buying at? And so ultimately that led to the creation of NADAC as a means to help satisfy a change in the regulation for Medicaid program that said it is no longer acceptable to pay at AWP. It's no longer to pay at an estimated acquisition cost or a discount to AWP. You must now pay at actual acquisition cost, AAC. And if you're curious about how you might comply with an AAC mandate that you have to do by 2016 when the covered outpatient drug rule is finalized, well, we, CMS, have created this NADAC survey process, which will potentially satisfy the AAC component. Just tell us how you intend to use it in your state plan amendment. So NADAC is a process by which CMS, through a contractor, surveys a bunch of pharmacies every month. And they say, please give us copies of your invoices with your wholesalers. And if you do, we will take that in, analyze it, create a composite view of, on average, across the nation, what does it cost to buy a drug? And we'll report that. And then states can use that to pay for drugs. a process this large and perhaps a little bit complicated does have a lag component to it, meaning that the survey goes out, it gets responded to, those responses get studied, and then ultimately published. So when we say the NADAC price in April 2025 is X, we're really saying a pharmacy 2 months ago when they bought it paid approximately X to buy it. It might be a little bit different today. As part of the change to AAC-based requirements, Medicaid programs were required to ensure that the total cost of payment was appropriate, which meant that not only are you paying the real drug cost, but you have to pay the real pharmacy cost. From those early, like 1970 investigations into AWP pricing, one of the things that the pharmacy community largely said in response to OIG or HHS or whomever was, drug prices are inflated in part because we don't get paid enough direct fees. There's not a real cost to dispense for our drugs. And so we have to inflate drug prices in order to operate. So as part of the mandate, a part of the change to the covered outpatient drug rule that says publish an AAC price across the nation, Medicaid programs typically incur much higher dispensing fees than other programs. When we look at the contracts later in this presentation, you'll see that typical commercial contracts today are paying 50 cents or less for a dispensing fee on average. We know through the work of Medicaid programs that across the nation, in every state, more or less, the cost for a pharmacy to take in the patient's information, screen for drug interactions or inappropriateness, put the pills in the bottle, put the bottle into the patient's hand is between $9 and $12 a prescription, which means if you're not going to pay $9 or $12 per prescription directly, in some ways you have to expect and or accept that the drug cost will be marked up to pay for that. And you can see that reflected in the NADAC equivalent benchmarks. I talked about how there is a relationship sometimes used between AWP and WAC, and it's not always the same for brand and generics. It's the same between NADAC and WAC or AWP. On average, a NADAC for a brand drug on an AWP basis is a 20%-ish discount. But for a generic, that can be a 90+% benchmark, depending upon which survey month we're talking about. And again, across the nation, we know that as states have changed their Medicaid programs to comply with this AAC requirement, they have changed their dispensing fees alongside of it. So if you take this slide and you keep in your back of your mind this AWP minus 80, 90% on generics, and you think about paying for drugs in the commercial space at these same rates, but you don't increase the dispensing fee proportionately to do that, what effectively happens is you put a squeeze on the operation of pharmacy. If pharmacy is getting reimbursed for drugs at or below their cost, depending upon the contracted AWP discount, and there's no associated dispensing fee or a very minimum one to do that, effectively you're creating unsustainable reimbursements for pharmacy based upon what we think we know from the Medicaid program and our approach to paying for drugs that has changed from AWP-based reimbursement to discounts to now AAC-based reimbursement. Alongside NADAC, which is this national survey of acquisition costs, states sometimes choose to do it alone or to supplement NADAC. So you also have this concept of state AACs. And state AACs is the idea that perhaps there's something about the NADAC process that you're uncomfortable with that you want to directly control. And so you will create your own AAC benchmark to do that. It can be things like the voluntary nature of NADAC. NADAC is a voluntary survey. A pharmacy who gets said, hey, will you give us your invoice information can say, no, I do not want to give you my invoice information. But a state can say, well, if you want to get paid by Medicaid, you're obliged to give us that information. They can create their own process to do that. In general, as you might expect, a mandatory survey tends to produce lower cost than the national average drug acquisition cost. Not all pharmacies operate their business in a way that seeks to get off-invoice discounts or other sorts of rebates or credits from their wholesaler. Some pharmacies just want to buy it as cheap up front, try to make the cash flow of having inventory on hand very low. So you might imagine that if you mandate an AAC, you're going to get more of a reflection of both sides of what pharmacy might be doing in regards to its wholesale acquisition cost. You also potentially see what's going on with regards to size and leverage. One pharmacy buying drugs from one wholesaler may not have a lot of leverage, as does a chain that says has tens of thousands of location and is buying a lot more drugs. They might be able to leverage that purchasing to get lower prices, which you can see when things are mandated. States aren't the only one with potentially a bone to pick around NADAC. You also have private companies. Predictive acquisition cost is a price that is not defined in federal statute because it is a company that takes a variety of inputs out there on drug prices, puts them into an analytical model and says, this is what we think the cost to acquire actually is based upon what we can see purchasing prices are and what we can see reimbursement is at, et cetera, et cetera. If you look, because this is an analytical approach to pricing, they tend to give a range. PAC is not just a value, PAC is potentially a low and high experience in what the price could be predicted to be. And you can get a lot of context from them around why they think this price is. They'll tell you what they see from other pricing benchmarks that is hopefully contextualized support for why PAC is the way that it is. So if we've talked about pricing from manufacturers and we've talked about pricing from providers, we now need to talk about pricing from payers. And the transitional prices that we'll use to talk about those prices are usual and customary and MAC. Usual and customary are prices that pharmacies set. MAC are prices that payers set. Usual and customary is arguably the granddaddy of pharmacy prices. When I said that in the beginning, prices were what the patient was willing to pay and what the provider was willing to sell it for, that is in effect what usual and customary is still trying to do today, is trying to say, if I walk in and no one walks in with me, I don't have an insurance card, what are you going to charge me to get this service? Usual and customary matters because in general, payers still use UNC as part of their payment logic. So when they contract with pharmacy providers to say, hey, take my plastic benefit card and ensure that people can go to you and get value from the insurance benefit that they're getting through me, the way I want to pay you is either this formula or whatever you ask for, whichever is less. So if you're saying to the industry, hey, you have abilities to maybe set price and we have an ability to set price, well, it shouldn't be surprising that in general, the financial incentive of providers is to upcharge their UNCs very, very high. If you're telling me there's a lower of payment logic here, well, in order to maximize perceived reimbursements, I should have a very high usual and customary price because it'll ensure I get paid effectively the most money possible. And unsurprisingly, like we saw with AWP, when there were lawsuits from people realizing that a higher price led to more money, there have been lawsuits related to UNC. There have been lawsuits where insurers have said, pharmacy provider, you should have given us access to a lower price based upon what you were doing writ large to everybody else. The grand bargain we made, the deal we made was lower of whatever you're charging to everyone else and lower of my payment paradigm. And I don't think I got that. And so whether it's through the financial incentive, these lawsuits, or something else, what we see when we study pharmacy data is that usual and customary, while a price that exists in claims throughout the land, it's largely not a price that influences payment. There's not an incentive, perhaps, for people to publish lower UNC prices into the system because it's not likely to benefit them financially. When we study pharmacy data, we can see, or we can remodel, if all payment were to change, where the pharmacy requested payment at AAC plus a professional dispense fee, i.e. something like NADAC plus $10, well, all the low payments that pharmacy gets perhaps stay, nothing's going to raise them, but all the high payments that they're getting that's above that current threshold go away. And that can be very financially harmful to pharmacies. In a study of Massachusetts pharmacy data, we saw that that change could be up to 75% of the total margin that pharmacies got over a 3-year time frame by just pharmacy asking for AAC plus $10. The data says if they were to do that, they would be more harmed than likely benefited. And this is because drug pricing as experienced by pharmacies from payers occurs across the spectrum, where you get low payments to high payments. This is one of my most famous images from work we've done at 3 Axes, which is this idea that if we take pharmacy reimbursement experience and we shrink it down into percentiles and we graph percentile 1 to 100, what does it look like from high to low? What we see is that the first script in the door in this kind of construct is one where the pharmacy bought the drug at a higher price than what they get paid for. They lost money just on the drug price alone. And they're going to do that for approximately the first 20% of everything that they sell. After that, they'll start to make really, really tiny margins that effectively dig them out of this collective hole from the drugs as they first got paid. And then at the end, they can potentially make a lot of money. So again, from left to right, first script in the door, a loss, subsequent scripts, a loss, but on a percentile basis, not as hard. We dig ourselves out of a hole, and then we potentially make our money. When we talk about AAC reimbursement under the current paradigm of lower of AWP-based discounts or UNC, we're talking about taking away the tail of these reimbursements in a way that's potentially very harmful to the business of pharmacy. And this is because the primary way that pharmacy gets paid is through MAC. Maximum allowable cost is a payer benchmark. Again, a payer benchmark that came about based upon what we learned about AWP over time. AWP does not have a federal definition or not a uniform federal definition. There's variability based upon what it means at state and federal level. But in general, industry tells us this is the idea that we saw with atorvastatin or Nexium, how one drug, one interchangeable drug can have a lot of different prices. And we need a way to say, don't just overcharge this, be aggressive, acquire the drug for as cheap as possible for us, please. So we're going to say, there is a certain price threshold for this product where we will not exceed payment on. If you try to sell us $250 generic Nexium, we know that's not the price, even if that's what AWP says the price is. We expect to be able to buy generic Nexium for like the over-the-counter price that we can see it at nowadays. So the history of MAC is, again, tied to AWP. We had these hearings on this brokenness related to drug pricing, this differential between what the pharmacy was potentially seeking in 100% AWP reimbursement and what we knew they to be acquiring the drug price for. And so in 1976, we said for a subset of drugs, we would like there to be a maximum allowable cost because of what we can see in the marketplace for competition for those drugs. This was before the Hatch-Waxman Act. This was before we had clear definitions and clear transitions between brand and generics and substitutability. There was still potentially some public distrust over whether generics were just as good as the brands they were seeking to replace, and potentially we're spending more money on these drugs because patients are perhaps hesitant to switch to them, and because we're paying for drugs in this AWP-based way. So if these drugs have these characteristics where we know that they're generally available, generally competitive, and commonly used, we want to say there's a maximum on what we're going to pay for them. So I talked about it earlier with Nexium, but here with atorvastatin, you can see why MAC becomes potentially relevant. Here is the AWP, WAC, and NADAC price point for all atorvastatin 40 milligram 90 count bottles in April 2025 from the various pricing benchmarks perspective. AWP is $500 or more in general. There are some atorvastatin products that have an AWP as low as $16, but not a lot on the left-hand side. In general, the WACs are all very low, $100 or less, $50 or less. The NADAC is even lower for that 90 count bottle. And in this effect, NADAC is kind of serving as a proxy to MAC. When we have one price that we want to pay, we're saying it doesn't matter if you try to source the $1,000 AWP product, we're not going to pay you $1,000 for it. Or if you're going to take an 80% discount, you might have the incentive to source the 1,000 count bottle because 80% off of 1,000 is more money than 80% off of 16. Doesn't matter what those incentives are. We want one price to control this experience. It's supposed to, according to industry, it's supposed to encourage effective, competitive pricing for these otherwise interchangeable drugs. But when so much of our experience is being dedicated or directed by NADAC-based or MAC-based pricing, what we recognize is that gives a lot of control to those producers of MAC over the experience of pharmacy. And so many states have passed laws trying to govern what MAC is and isn't, how it works and doesn't work in its state. And what has largely been perhaps the impetus behind this is providers saying MAC doesn't seem to do what they're saying it does. If you use NADAC as a proxy and you measure MAC changes in response to NADAC changes, you can see that they don't always move in the same direction. In work that I did at Free Access, we saw that even though NADAC might signal that a drug is getting very expensive because of a shortage or whatever else, the MAC price isn't necessarily moving in alignment with that price. If it's easier, I gave a specific example on the next slide. You can see that for these various PBMs, each of these buckets is one different PBM in the aggregate across a group of pharmacies. You can see that as the NADAC price for losartan, which is the same for all of these PBMs experience, went up, some prices went down. Some prices went up in relation, but not always, and often not in the same direction. And this happens because there isn't just one MAC price. The perception even from this is perhaps a little out of whack. This gives an idea that, well, whatever the first PBM on the far left is doing with losartan, even if it doesn't make rational sense, there's still a losartan price. When you unpack MAC prices, what you can see is that the same PBM on the same day for the same drug at the same provider can set many different prices for that drug. So again, while you might think that there is one MAC price, one maximum allowable, one best incentive for the cheap purchasing of interchangeable drugs, what the data shows is sometimes the drug is being sold for $10 to one patient in one plan, while at the same time being sold for $1,300. So arguably, this has led to plans starting to potentially take control of drug prices themselves, or government seek to take control of drug prices themselves. The last group of drug prices, before I'll stop and take some questions, is what do payers do directly in the drug pricing space? Well, in this area, we're going to talk about three. The oldest is the federal supply schedule. The federal government and its various agencies sometimes needs to buy drugs, whether that is responding to a disaster or just taking good care of servicemen and women. They have a need to get drug supplies in various different scenarios, and so they would like to buy them. But they also recognize that the way that our drug pricing system works is not necessarily conducive to the best bang for your buck from a value prop of their organizations. If we live in a world where a brand drug can be 23% off in the minimum to Medicaid, or often 50% or more off based upon what we've seen in various reports, why would I pay $100 just to get a $50 rebate later? If I am in a disaster scenario, far better for me to buy two $50 vials than just spend $100 on one. And so the federal government negotiates directly with manufacturers for access to drugs at fixed prices in a way that generally reflects their net price without rebates up front. They differentiate the access to these prices based upon an aggregate federal supply schedule and then specific pricing for their biggest agencies that use drugs. So they get even better prices for the government when there's additional leverage to get extra concessions. If you are the Department of Veterans Affairs, Department of Defense, Public Health, Coast Guard, you know that you're going to likely use more drugs than just a different agency, and so you get better prices. The government has studied this. If you use Medicare as a proxy for drug price, what Medicare buys for 100, the federal supply schedule will get for 93, the big four price will be 80, and the VA can get that potentially for $55. Even so, we also know that still no one does it better than Medicaid. That same thing that Medicare is buying for 100, Medicaid can get for 35. And so of all these programs that we're talking about, the one who arguably buys the most, at least on a dollar basis, drugs is Medicare, Medicare Part D in specifically. And if you see something like this, you might think that perhaps the status quo for the way that Medicare is experienced pricing isn't working. And so one of the things that's changed semi-recently was the removal of the non-interference clause in regards to Medicare. When Medicare first conceived of a drug program back in the early 2000s with the Medicare Modernization Act, one of the things that was put in as a regulation was the government was prohibited from interfering in drug price negotiations between manufacturers and insurers. The Inflation Reduction Act amended this to say that for a subset of effectively defined drugs, the government would be allowed to start negotiating prices on those drugs, in effect enforce a oneness of price that it perhaps wasn't seeing or experiencing previously. The first 10 drugs have already not only been selected, but negotiated, and we know what those drug prices are going to look like in 2026, and have a sense that in general, they're securing a discount on these drugs that is effectively, in the aggregate, 60% off their list price experience on expenditures that represent effectively 20% of every dollar that Medicare buys. And this is not the end of it, because we know the next 15 drugs that they're going to do for 2027 that are currently on negotiation, and we'll learn those prices this year. So I know that by now you probably are tired of listening to my voice. I know that that was a lot, but this is the point where I would like to break shortly to see what kind of questions you have over the drug pricing benchmarks before we start talking about how they actually get used.
And Dr. Link, I'll help moderate the questions, and I'll also let you grab a drink. Very, very impressive. One thing I'll just note is that I probably had to listen to your podcast maybe 5 times or so to be able to process everything you just said. So just flagging for everyone on the line that this was a lot of information, and the more you listen to it, the more it'll make sense. Then also it's probably worth going back to specific sections if you have questions about specific sections. I wanted to just ask two questions that I've received from board members different stakeholder council members that I've had trouble answering. The first one is there something about the prescription drug market that is fundamentally different from any other retail market? Like when people are asking, like, what's so weird about prescription drugs? I only know prescription drugs, so I don't know the answer, but they often say, like, in the retail space, it's very common to see, volume-based discounts, off-invoice rebates, wholesale marked up to retail that can be very significant. Is there something that's fundamentally different about the prescription drug space compared to most other retail markets?
So I would say that in my opinion, there is, and just that is primarily along the role that the insurer plays in marketing of price or effectuating price. I don't think marketing is what I want to use, effectuating. Because if you think about what a grocery store does, if I want a higher price for milk, I set a higher price for milk, and I effectively see a higher price for milk across the board. I might send a group of people a coupon, right? And a subset of group might get a better price, but I largely controlled that as the merchant. When it comes to prescription drugs and the way that we contract, there isn't necessarily that guarantee that if I, the retailer, want X, Y, or Z product to be more profitable, my contracts don't normally give me a means to ensure that happens. I can potentially raise my UNC, but that's by and large not a price that influences anything. And so the key difference that I see is that price as experienced by both the patient, the plan, whatever, is largely a concept that is governed by a contract. And that contract has more of a role than, say, the merchant.
That's helpful. And then the second question is, could you, and this might not be a fair question, you can just punt on it if you don't want to. Can you summarize your last hour and change of a presentation into your elevator pitch of how the prices and or reimbursement has changed over time? So back in the 70s, pharmacies were reimbursed at this, then this problem happened. Then in the 80s, they reimbursed at this all the way through the 2000s to here. Like, as quickly and concisely as you can.
Yep. So,
yeah.
And again, I actually have a slide in my next section.
Okay,
It's a quick review, but it is, we went from where effectively the providers were setting the price, and that is largely conceptualized by a time of 100% of AWP reimbursement. And that was largely from 1969 until 1989, about 20 years. And then we went to a role where the MAC-based pricing dominated, or estimates of acquisition costs, where we're using AWP-based discounts. And we are in a transitionary phase where our market is becoming bifurcated. Still, the predominant way that prices are experienced is this AWP-based discount, but you're seeing an ever-increasing interest in how do we achieve actual acquisition costs. And you can see that reflected in announcements of the big three PBMs, as well as like payer interest in non-AWP-based contracts in the RFP or other process.
Very impressive. Thank you. I saw that Dr. Tunis had a question, but I'm not sure. I saw his hand go down. Go ahead, Dr. Tunis.
Yeah, hey, can you hear me okay?
Yeah. Yep. Yes, we can.
So a couple of comments. First of all, that was a master class. I really appreciate it. It was way more interesting than I was expecting, so thank you. The second comment is I'm really glad that we have Andy and his team to sort this out in the context of what to actually do with upper payment limits in Maryland. My question for you is, do you know if anyone has done the analysis on the Medicare, MFPs for the first round of negotiation, and the other, you showed a slide with like the VA prices, DOD, what they pay, what Medicaid pays. This reflects Medicare Part D before the MFPs. So I'm just wondering if the IRA drug price negotiations have brought the Medicare prices more in line with these other federal entities.
So to answer your question, I'm not aware of any analysis that has attempted to recreate this learning. I can say that we know that there is some, or at least we believe we know from the federal government has told us that the prices they negotiated are slightly better than the net prices as they were experienced at the time of negotiation. Now, there's obviously a disconnect from when they were negotiated to when they're in effect. Maybe the market would have moved to that same net level over time. We don't know that. but there was at least some improvement in the net price experience compared to what it was. I don't remember the exact percentage off the top of my head, but at best, my recollection is it would make it more like the federal supply schedule, not like the VA or Medicaid or whatever have you. We're not talking about extra discounts that were so much better that the price is, half of what we thought it was historically in the net.
Okay, thanks. And then just, I don't know if later in your presentation, you're going to be sort of talking about, I guess now UPLs gets added to the alphabet soup of drug pricing terms. I don't know that it's been fully defined yet, although I know, Andy and the team have been working hard on that. But it sounds like maybe we're potentially moving in the direction of linking upper payment limits to things like maximum fair price or other existing benchmarks. I'm just wondering, I guess the question is, will UPL eventually be subject to the same, all the same kind of challenges and issues that, AWP and, the acquisition costs, et cetera, are, will it be possible to be defended any better and, have it more understandable than some of these, what you have on the table here?
Or I think the easiest answer is until it is defined, it is unknown. It's certainly a risk, but it's not 100% we're still not, for example, even though we know what CMS's maximum fair price is and will be, we don't fully know the effect it will have in the market because we've yet to actually live it, right? There's papers out there saying, papers that 3-Axis itself has written that says, we see potential concerns with access where providers may not want to stock these drugs, or maybe they do want to stock these drugs. It's not 100% clear because it's not been lived yet. And so until such time as it's established, and then until such time as it's in practice, I think you just have to acknowledge the risks that certainly negative things can happen with whatever is done, or good things. It's just unknown.
Yeah. And I guess the last comment is, and then I'll shut up, is it seems like what the common characteristic of, how all of these benchmarks became sort of, difficult to understand is that, it's the sort of all the different entities in the supply chain sort of figuring out ways to maximize, revenues and, within, and kind of playing with the benchmarks, however you could kind of, achieve that sort of each player in the supply chain kind of maximizing their, revenue, which you would expect. But I guess that dynamic seems like, fundamentally, unless there's reforms, whether it's PBM or other kind of reforms, it's just going to be hard to get your arms around this, these drug pricing issues.
Yeah, I'd say the question that I heard in there is largely a recognition that our system today seems predicated off of discounts. Discounts are most valuable if the starting point is high, not low. The higher the initial number is, the easier it is for me to cut off a piece of that and provide to somebody else. We see in this NADAC equivalency table a representation that on an aggregate basis, NADAC is the lowest pricing benchmark for drugs, whether we're talking about AWP, WAC, or whatever. But it's not necessarily the predominant way that we see drugs priced in contracts. And in some ways that teaches us that we are currently valuing the ability to discount and leverage potentially size, scale, and differentiation prices more than we are leveraging or valuing or appreciating what a single price can do to rationalize or otherwise create transparency in a place, in a market. So.
Great. Well, thanks a lot. Thank you.
And then Dr. Golden?
Yeah, so great overview. And I listened to the podcast and I've been taking notes. I'm trying to keep all of the prices in mind. So I think the thing that struck me in all of this is that, the PDAB is actually sort of charged with coming with an upper payment limit. And then it occurred to me, what is actually our baseline that we're coming with an upper payment limit for? Because I was struck by in the beginning of one of your podcasts, you were like, there are actually 9 different drug prices. And it seems like now there's actually more than 9 after listening to you today. So if we're setting an upper payment limit, like what target are we starting with? Like which of these measures is the right one to be setting an upper payment limit for? Like maybe that's obvious to everyone else, but after listening to that occurred to me that wasn't completely clear to me anymore.
Now, by my count, I talked about 14 prices here, which is part of why it took so long. And again, that is more than was on the podcast episodes, though many of them overlap. And I think that the key thing in your question that I can at least provide context on is that whatever is done with an upper payment limit is going to exist in a place in a context of the rest of the market, and what the rest of those dynamics are can shape how effective or ineffective or whatever that experience ultimately is.
And I would just echo Dr. Link's point. I think that is the exercise of the board and the stakeholder council, is to navigate this complex supply chain and this complex pricing system to understand exactly what the board is trying to do and how it'll flow through the market. So that's why we appreciate such a great primer on this issue. Any other questions from the stakeholder council? If not, we have 2 more sections, so I'll hand it back to Dr. Link.
These will be much quicker than the first, so I promise you won't have to listen to me as much. I wish there was a better way to break that up, but if I stop talking about benchmarks halfway through and then go back, it seemed like it would be more confusion. So we already kind of revisited them, and we didn't spend that long in discussion on the questions. So I'm just going to dive right into what we see from public sources on how drug prices get used in the system. And so here's an example of the city of Mesa in Arizona. Again, I didn't find one necessarily for Maryland or even Ohio, but you can see that as the city of Mesa secured their contract with their PBM, they did so in a way that recognizes drug prices in relation to AWP prices. That's not to say that each and individual transaction they see will be these prices. Their contract, which you can look at and see in its full context, is saying that the PBM is guaranteeing the aggregate experience will be effectively this. And this is segmented not just by brand and generic drug, not just by drug type, but the experience is also segmented by pharmacy claim type. So retail pharmacies have a pricing experience that differs at effectively the 30-day basis, that differs from what it is at the 90-day basis, which differs from what it is at the mail order basis, and what differs if it's a specialty drug or pharmacy dispensing the drug. The concept of what sort of prices they're going to experience is tied to AWP. And as I alluded to earlier, if I go back a slide, and on this slide, you'll see that the dispensing fee component is largely not there. If we know that the dispensing fee cost to operate a pharmacy is between $9 to $12 a prescription, if you're signing a contract that is saying you're paying a 45-cent dispensing fee or $0 dispensing fee, in some ways that contract would seem to acknowledge that you're inflating drug costs as part of paying the provider. And then if you potentially talk about high drug prices, are you talking about them in a way that is representing that part of the price at issue is some of the pharmacy's compensation? Right? The way I try to draw parallels here is if you think about what would it look like if tomorrow Google started charging us for search engine searches. If you had to pay a nickel, a quarter, a dollar every time you said, hey, Google, how do I do this? What would that look like, and how would you value Google as opposed to today where you pay nothing for it? There's obviously cost associated with the infrastructure of doing that, but it's not clear in our current arrangement with Google or our current contract arrangements exactly where that value is potentially being divvied up. If your drug price comes in the aggregate above one of these thresholds, was it the pharmacy provider's fault that that was higher? Was it the PBM's fault that it was higher? Or was it something else. Also, because our experience is along these contracted AWP-based discounts, there is the opportunity to create exemptions, things that don't count towards your overall guarantee. It also means that if you are the payer responsible for managing these drug costs, well, what guarantees do you have that you're going to get rational, reasonable, or otherwise fair prices if the drug falls into one of these categories? Depending upon your contract, you may or may not have any sort of recourse on what the contract says you can do in regards to prices on these drugs. And while I recognize that I am totally picking on the city of Mesa just because it's a contract that I found and had on hand that was reasonably current for the conversation of today, we can also see that when groups go out to bid, like here, San Juan County, and I believe Utah, going out to bid seeking PBM services, when they do so, they're evaluating the various PBM pricing bids in relationship to those AWP-based discount. While I unfortunately can't get it super clear on the image, I promise you if you go to that link, or you could otherwise zoom in, the brand discount across these more than 6 PBMs that are bidding on this business are AWP-based discounts. It's true for the generics, it's true when they're mail, it's true when they're specialty. We are evaluating drug prices in an AWP-based arrangement, which, as a reminder, is an arrangement that takes drug prices to arguably the second highest level, the highest being UNC. So if AWP-based pricing is the control over our experience, what does it say about the incentives to actually seek out low drug prices? I showed you that for equally interchangeable drugs, there can be a huge delta between the low end of AWP experience and the high end of AWP experience. You don't have to be an actuary to know that if I can get an 80% discount off of something that's $1,000, I'll make more money. Well, if I'm incentivized to seek out those kinds of drugs from the payer's experience, that's going to shift your drug mix to potentially higher AWP-based drugs, potentially reduce the value of the discounts that you're seeing. One of the points I didn't make, but I'll go back and make real quick, is that also, what does it say about the PBM that they can guarantee changes in AWP-based discounts over time? If you look at the generic effective rates over time, they increase every single year for the course of this contract. Well, if you know that brand drugs are going to go generic and those generic drugs are going to have AWPs that seem a lot more like brands, you potentially can discount them more over time just automatically based upon the way that we know this system moves in the aggregate. And while there's not really county or state or city-owned pharmacies that I could find contracts to in the public domain to show you, I can assure you that in my experience as a consultant, these types of terms generally mirror what's seen in the pharmacy network space. It would make sense if you're a PBM contracting with both payers and pharmacies, you'd want to use similar language from a management standpoint. And so even though I don't have a pharmacy network contract to show you, I assure you that in general, those contracts do very similar thing, aggregating drug pricing experience to an AWP-based discount and segmenting those experiences by the type of claim and where that claim occurs. Switching from perhaps the other end of the spectrum from how drug prices get used in the drug supply chain, not from the PBM intermediary and the network of providers, going from the drug manufacturer and the PBMs, we know in general that drug prices are used to provide rebates to PBMs. We saw with Medicaid that the base experience of rebates is one where the rebate is a percentage of the drug's price. In that case, it was AMP. In the private commercial space, it's often not AMP, but WAC. In part, it's because nobody gets to know what AMP is unless you're the drug manufacturer or the federal government in the Medicaid program. So if you don't have AMP to rely upon for your negotiations, perhaps the next best thing you can do is use WAC, or wholesale acquisition cost. For the removal of doubt, let me be clear. When I say rebate, I mean this idea that I, as a drug manufacturer, can provide monetary value to the health plan, to the PBM after the fact, for the purposes of promoting or otherwise discounting my service. There's a lot of language and legislative history and legal history, lawsuits that have gone into what is and isn't an appropriate kind of safe harbor discount. But for us passing a law that said it's okay to provide this kind of remuneration, we would otherwise call this a kickback. We had to create an exemption to the law that said it was okay to pass this kind of money this way and not violate the anti-kickback statute. But we know from the opioid lawsuits that have put rebate contracts into the public domain that opioid rebates were by and large a percentage of WAC-based experience, a percentage of WAC-based experience that potentially differentiated value based upon product line over time, as well as based upon what kind of status the drug was given on the formulary by the health plan. The formulary being the rules of the road for when the health plan will help pay for drugs. If you want to take drug X, your insurer might say, well, we need to get a prior authorization from your doctor to determine that X is the most effective medication for you. Sometimes that can be ensuring it's clinically appropriate. Sometimes it can be ensuring it's cost effective. Oftentimes it's an overlap of both. But we can see from the Senate Finance investigation into the insulin drugs that drug rebates can vary based upon how much how much access is potentially being provided through the formulary. If the product is exclusive, meaning you have to use me over my competitors, there's potentially greater rebates than if the product is co-preferred, one of two products, or just listed on the formulary at, say, equal or parity to everybody else. We can also see from the Senate Finance investigations of the insulin manufacturers that not only are rebates based upon this formulary status and this drug pricing experience, but administrative fees are a percentage of that drug's price. So we have many different ways to take pieces of the drug's price and provide value to other members of the supply chain. Rebates might be calculated based upon WAC, that manufacturer price point, but experience at the pharmacy counter is calculated based upon AWP, a largely in the aggregate inflated experience to WAC. We saw that earlier. For generic drugs, that can be a 9-fold greater difference. For brand drugs, that can be 20% more than the underlying WAC price. All of this has enabled us to study through aggregate disclosures of manufacturers, health plans, et cetera, that drug prices are moving often in opposite direction. While the list price experience that we see on a WAC basis is almost guaranteed to go up year over year in the aggregate for drugs, the net price is the price experienced after all the discounts and rebates and other sorts of pieces are given away to various members of the drug supply chain. The net price is potentially going in the opposite direction. We can see that in the aggregate. We can see that from public disclosures of specific drugs. Before the insulin manufacturers, by and large, took their price decreases on their insulin products, we saw a big disconnect between what the list price of a thing of insulin was versus what its net price was. And so we're in this very interesting paradigm where, depending upon which price we're talking about, we're potentially talking about very different experiences. We can see this in aggregate Medicaid data. Some people talk about Medicaid currently spending $100 billion on drugs, at least in the last year that we have that aggregate data to talk about. But in reality, Medicaid got more than half of that money back through rebates, the net price experience, because we know Medicaid is the best place to be from a net price experience. We know that those rebates are very valuable, can be associated with big discounts. There was just an article published in a paper about a drug manufacturer who raised their price over 100% this year. And they know that by doing that, they're going to pay big penalties to Medicaid in terms of rebates. But they still potentially think that that is what's in the best interest of their company's bottom line, because in effect, the experience of non-Medicaid payers will, in their estimation, hopefully account for or make up for the difference of what they're experiencing. And so as we did earlier, when we're talking about the importance of drug prices from the point of view of financial disclosures, let's do that from the big drug manufacturers. Again, these are snippets, not fully contextualized, not financial advice. But if you look at what the drug manufacturers tell potential investors on their annual 10K reportings, they say, by and large, the payment system in the United States requires them to give rebates. Oftentimes, there's a statutory reason for why they have to do that. Things like the Department of Defense, public health, Medicaid, whatever. They also state that they know that they're giving these price concessions to effectively ensure their drug has a place in the market. Rebates and net costs are increasingly important factors in formulary decisions. So if you as a supply chain are sending a signal that we expect to get some of your value back after the fact, then perhaps we should understand that there is going to be incentive, desire, whatever the reason is, to inflate that starting position just to provide more opportunity to discount. According to Bristol Myers Squibb, their US sales, their gross to net adjustment is approximately 50% off. What does it say about our perceptions of drug pricing if the net experience of the drug price is effectively half what the list price experience is? There's a lot of value that is potentially going to the rest of the drug supply chain through these various price concessions, discounts, and other sorts of giveaways from what the drug's price is versus what we actually pay for in the net. And when it can be so varied across payers, across patients, if the same drug on the same day can have a different patient price experience or plan price experience, and if the payers across this country can have various different price experience, in essence, the point I guess that I'm trying to make is that when we think about drug pricing in the United States, the 14 different price benchmarks tell us, in effect, there isn't one answer to the drug price. Somebody may get for very cheap what you pay a great deal for. We saw this with insulin. Insulin is a drug that was effectively penny priced at times through the 340B program. That meant that there were certain providers who could get from the manufacturer the drug for at or near a penny for the full thing, while at other times there were payers paying $300 for that same drug. In essence, it doesn't necessarily matter what an international price or whatever somebody else's price was. Your price is going to be experienced on a spectrum that may vary day to day, provider to provider, insurer to insurer. What is your most expensive drug today as a health plan could switch tomorrow if something or nothing changed. That is the arbitrary nature of our drug pricing that we see from these contracts. So I'm going to pause there. That was my next section. I promised these last ones would be quicker. We have one more after this, which is the examples of drug pricing in practice. But are there any questions about drug pricing benchmarks in the pharmacy channel?
Okay, so we'll look for hands. As we wait for hands, I will ask a quick question based on the contract that you showed with the pharmacies. And I can get you the slide number in just a second. But you showed some pretty amazing discounts off of AWP. And then you mentioned that the pharmacies also are getting no dispensing fee. So that means that they're probably making margins off of the drug. So I guess I just wanted you to confirm that like AWP, looking at the generics, minus 84.75%, still leaves a margin for the pharmacy, or do you think they're generally underwater? That might be a loaded question because I knew pharmacies are saying that these contracts are getting more aggressive on their reimbursement. But would I guess
Yeah, I can answer your question. I understand it. So, I mean, I would say let's look at it in reflection to NADAC, right? If we understand that on the average or in the most common occurrence where pharmacies are at with buying drugs on a generic basis, and we compare that to this contract, the contract suggests that payment is pretty close to the same, right? And if there's not a dispensing fee associated with that similar standard of experience, that would strongly suggest that there isn't a lot of money for pharmacies in this space today. And it might explain observations like Walgreens closing a bunch of stores, or CVS, or even the mom and pop closing their doors. At the same time, I would remind you that we did mention that NADAC's methodology is just the invoice, and we know that off-invoice discounts exist. So it's not that it is perhaps as dire as it seems on its surface, right? If you need 9 and you're getting 45 cents, that would suggest that there's absolutely no room to operate. So there must be some room to operate that's not fully contextualized just at that high level benchmark comparison, but it gives us insight into certainly where the market seems to be and where pharmacy experience might be.
very helpful. Any questions from the stakeholder council? Not seeing any. If you have any voice left, you're welcome to go into the last section. Very impressive, by the way.
I got it. I got one more section here, and hopefully this will explain some of why drug pricing doesn't do exactly what we think it does, despite our contracts, despite our complexity and benchmarks and all that jazz, and why what we experience is in sometimes, not what we thought we were signing up for. The first one that I have is one that we did at 46 Brooklyn, which is where we viewed money from sick people and we viewed rebates as effectively money from sick people. If most spending in the prescription drug space is on brands, and we know that most brands produce a rebate, and that oftentimes for at least big shops like we saw with Bristol Myers and Squibb, that rebate can be half off or more in the aggregate. The question becomes, can we follow the dollars, so to speak, to try to get a sense of why our system of a high price discounted down is the prevailing system, especially when a lot of the rest of the world seems to go with a more lower price up front and add charges as it moves through the system. If you look at like what Denmark does, Denmark sees a price, they say this is what it's the wholesaler is allowed to do with marking up that price, and this is what the pharmacy is allowed to do with marking up that price, but we're going to monitor it across the way. Well, we used insulin, and this was before insulin took the price decreases, so it's a little bit dated. But if you think about the standard benefit that a person has, and they're going to take a drug that is brand that produces a rebate, well, most people have a deductible, and so you have to pay the drug's cost up front until you meet your deductible, in which time your insurance benefit will provide discounted prices. You'll pay your 10% of the overall drug price, and the health plan will pay the majority of the drug price. But while you're in your deductible, the drug is still producing a rebate. And that rebate lead that the plan gets can be sufficient that by the end, the plan didn't actually spend anything on giving your insulin. The plan made money. They collected these rebates. They got the rebates when they had to contribute more, but their net cost wasn't that high, such that they ended out ahead. And so this can enable plans to potentially invest that money if that's what they choose to do. They can lower premiums, try to be more competitive on the benefits they're offering. They can provide lower fixed copays across the board when they're met. But in essence, this person's rebate that produced this value, they didn't see the full-fledged benefit of that discount. If the net price would have prevailed from the very beginning, they could have just paid $69 every month. They would have never even met their deductible over the course of the year. If they never met the deductible, the health plan cost would be zero. But zero in the net is not as good as negative in the net. And so we can start to use our drug pricing benchmarks and these contracts that we see to start to try to conceptualize why our experience is the way it is. Another example of this is potentially GoodRx. GoodRx is a company that tries to help people get more affordable drugs, a very admirable goal in our very complicated, messed up system. It does so largely in partnerships with PBMs. Uninsured people, while they're not the predominant pharmacy customer, they do exist. And if they don't have a existing PBM relationship through their employer, through a government program, whatever, GoodRx can say, well, you might benefit from some of those relationships through using my card as opposed to having one directly as insurance. Now, the way that this works transactionally is you present the card to the pharmacy just like it were insurance. They're going to adjudicate it effectively behind the scenes to a PBM who is going to tell the pharmacy not to charge their high inflated UNC, but to take a lower PBM negotiated rate. But at the same time, in order to pay themselves, GoodRx and the PBM are going to collect a fee out of that. So the patient might be told through your GoodRx card, this drug that was otherwise $100 at our usual and customary can now be given to you for $20. The pharmacy's reality might be that they actually only see 13 of that $20 because PBM/GoodRx are taking a fee out of that $20 collected from the patient. And GoodRx is taking advantage of what we saw with MAC prices. Our earlier learning when the same drug can have many different prices on the same day means that GoodRx can look at the variety of partnerships that they have and say, well, you patient who wants emtricitabine, whatever, if you have not insurance, or even if you have insurance that's going to charge you a lot, I have access to a price that is potentially low. This is why people sometimes use the GoodRx card over their insurer's card, because the experience of drug pricing on the generic basis is not one. Again, while we might see there be a theoretical prevailing price for a given product under a given PBM, that's not really what the data shows us underlying. The data shows us that there can be a breadth of experience. So taking this chart and trying to recontextualize it, if you are currently experiencing this price, well, this PBM's price would seem much lower than this price, even if it's higher today. So maybe you, patient, would benefit from coming down to this price. So even if you have insurance, you might want to use me as opposed to them. Now, as you might imagine, this can create a competitive or a financial disincentive for pharmacy. We talked about how pharmacy is dependent upon a few percentile of their claims being a large portion of their margin. If those claims go away, such as taking an otherwise $1,300 reimbursement down to $10, that can be very damaging to the pharmacy, especially if they have to then pay a finder's fee or whatever you want to call it to GoodRx and the PBM for transacting that claim through them. So over time, GoodRx's model has changed. GoodRx had is no longer as necessarily reliant upon the PBMs, though that's still clearly what they are, and that's what their 10K tells us. They are moving to a place where they potentially contract with pharmacies based upon using all the PBM networks, specific networks, or one PBM for that pharmacy, or even just going directly to the pharmacy themselves and saying, what kind of drug prices can we get that are reflective of our value in the system and what you're willing to accept. So as I did before, if we look at what GoodRx tells its investors, it tells us that PBMs are already doing this job of aggregating their pricing and getting benefits through their network, and we can create incremental volume additions through partnership with them. They're telling us that the largest source of their revenue, even though they have other programs like manufacturer partnerships or subscription-based models with patients, think like a Netflix service, that they generate the majority of their prescription of their revenues through this traditional retail pharmacy discount approach. What's potentially interesting is that substantially all of their revenue, according to their 10K, is generated from brick and mortar pharmacies, which are potentially, depending upon what the net experience is, risking a good portion of the margins that they need to operate with GoodRx. So again, GoodRx has said that we're not just a discounting platform, or not just taking advantage of PBM-based discountings, we're also potentially taking advantage of manufacturer-based discounting. Manufacturers can partner with GoodRx as well to effectuate discounts on their products, not necessarily derived from the PBM reducing it, but because the manufacturer is offering copay or other sorts of assistance through the GoodRx platform. Again, we should understand that the majority of the revenue is the discount transactions. The majority of the value seen with the services they offer today is being realized through what they're doing with taking disparate and varied drug pricing and making sure effectively the lower price prevails to the extent that they see it and have access to it. We know from lawsuits that the value that is being taken from pharmacies is alleged to be between $7 and $10 per prescription, which if you think about what the average drug cost in this country is, and this is reflective of both brand and generic cost, you're talking about somewhere in the range of 30%-ish of that average healthcare transaction being captured by them in the generic instances, significantly less in the brand. On a brand basis, this would be like 1-ish%. It's no surprise then that the net effect is something where, 15 to 16% of the margin that the pharmacy might think it would otherwise get may be at risk to being captured to a fee or whatever. This is becoming more interesting or more of consequence to pharmacy because PBMs and GoodRx have started to integrate. PBMs are facing a lot of pressure from their customers saying, why am I contracting with you when GoodRx is showing an even lower price than my contract with you would see? And so GoodRx and select PBMs have announced partnerships where they say, well, we can integrate with your software and effectuate the lowest price without having to jump hoops between us. We can smooth out that experience for our customers. But this has led to its own sort of lawsuits saying, well, perhaps there's some anti-competitive behavior or price fixing going on when all of these parties are coming together to effectively coordinate and act on prices. Those lawsuits are pending, and so this is all unknown whether this is or isn't harm, but I bring it up just for completeness sake. The last, I'm almost done, talk on drug prices that we're going to talk about is the Mark Cuban Cost Plus Drug Company. The Mark Cuban Cost Plus Drug Company sells directly to patients drugs. It also has a retail network that potentially partners, kind of like perhaps what GoodRx does, to effectuate lower drug prices, but they started with selling prices directly to patients. In essence, they returned perhaps to pharmacy's roots, where the price was the price between the pharmacy and the patient. And they did so by saying, look, we're going to tell you what it cost us to buy the drug. If in essence, a lot of our drug pricing efforts can be boiled down to figure out what it costs to buy the drug and pay that, they can say, well, we'll tell you what it costs to buy. We will take a markup that you can see on it and then charge you to get it based upon what it cost us to buy and what it cost us to get it for you based upon the profit that we want to do this service. And so they have been arguably quite successful. There's been a lot of coverage, undoubtedly tied in part to the fact that Cuban's name carries weight in the media regarding this program. They have made select partnerships with insurers over this. And part of this boils down to, well, if you're talking about a traditional contract might not have a role for a cost plus pharmacy to operate. And we can see this with the first product they launched, which was albendazole. This is the Mark Cuban cost plus price of albendazole. The rest is competitors. When it was launched, what you can see is that the price of their drug is marked up 20% to create an AWP price, but their price is much lower than effectively everybody else's price. But if you're a pharmacy in a contract that says you must accept AWP minus 85% as reimbursement for your generic albendazole, there is no effective room in most of these drug instances, at least measured by AWP and WAC, for the pharmacy to buy this product and actually do so in a way that's profitable to dispense it. Said differently, if I were to inject Mark Cuban into the traditional PBM contract, whether that's payer and or pharmacy experience, it wouldn't work. It would have to become an exemption to those otherwise aggregate discount guarantees that we're talking about. From a different point of view, what albendazole enables us to do is try to create a kind of complete perspective on generic drug prices. At the time when albendazole was launched, Cuban was telling us that it cost $13 to acquire from the manufacturer, when the NADAC price at the time it was launched was something like $73, a big markup potentially on what may or may not be possible. Some of that is going to perhaps the pharmacy and off invoice discount. Some of that is being withheld by the manufacturer or by the wholesaler, who themselves makes money off of the sale of their generic drugs to pharmacies. We can see that based upon how the pharmacy sold it to payers, there was potentially a big difference between what the pharmacy experienced in price and what the payer experienced of ours. Pharmacy could make money and the PBM could make money through spread, and the payer might still perceive, based upon AWP, a big discount on this drug. I'm not paying the full drugs cost, I'm paying half or less than the full drugs cost. So unlike a system which might try to take each drug and add a little bit of cost across the way, our approach to discounting says that there can be big steps along the way sometimes for drugs, depending upon our knowledge of what's going on with that drug. Cuban has been reported to provide a great deal of savings to select partnerships. Perhaps there are those where they haven't achieved those savings, depending upon what's out there. But in general, what is being reported is that when Cuban and a system or a PBM or insurer partner, they are doing so in a way that's very value add, that if you know what drugs cost and you pay what those drugs cost, there is potentially savings to be had in the aggregate. So that concludes my presentation. I believe it's 2.5-ish hours later, so I understand if that was a lot, but the last little section I have is just to conclude, but I'll stop to see if there's any questions.
All right. Seeing no questions. I did find this to be, oh, go ahead, Dr. Tunis.
Yeah, again, thanks so much for the clarity and the thoroughness of the presentation. This is just prompted by the Cuban and GoodRx features or programs that you went over. And I'm just wondering, we've obviously been, the Stakeholder Council and the PDAB have been very focused on the upper payment implementation of the upper payment limit, and I'm just wondering whether some addition of some kind of patient focused discount program would still be potentially beneficial even in the context of the upper payment limit, policy mechanism, if that made sense.
So again, I can't speak for what drugs would be given in the upper payment limit or whatever. I would just say that in general, right, price support that manufacturers provide according to their financial and other statements is predicated off of knowledge that people have deductibles and other things that influence the patient cost experience. Depending upon what an upper payment limit looks like, that may or may not mean that there's still a value to providing those kinds of services to whatever ends that they have. So I know that's kind of a very weak answer to your question, but I think until such time as it's clear about, what an upper payment limit is and does, like Medicare is potentially a good parallel, but we also know that like discount cards, coupon supports are generally disallowed in the Medicare system. So we won't probably learn much in relation to that as Medicare moves forward with its negotiated price. But that's what we know today.
Hey, Andy, it's Van.
Yep.
Dr. Link, first of all, thank you very much for your presentation today. And I hope the stakeholder council, although some of them had to drop off, I hope they'll go back and review the whole context. My question comes from a little bit different angle that I've been grappling with for 5 years, having come in out of the lumber and building supply home center industry and been very close to the gasoline distribution industry over the years. Have you ever looked at why this is so convoluted compared to all of our other wholesale commodity industries in which we have manufacturing, distribution, and retail? I've dealt for 50 years in some of these industries, and we never have these kind of issues. We never had these problems. Sure, mom and pops go in and out of business, bigs get bigger, but you basically figure out a way that you're going to stay in business one way or the other with your marketing and the SKUs and everything else. And I guess I just find it so interesting that this industry is so, from a pricing standpoint, so mysterious and so strange compared to any other thing that we do in our whole world economy.
So I would say I'm not aware of any specific studies that have attempted to draw direct parallels between prescription drugs and other commodity industries. In my opinion, right, the commodity industry is kind of dependent upon transparency around the commodities. You need to be able to provide, say, a futures contract for that to say that we need or we perceive that we're going to need value in this going forward or whatever have you. That isn't really possible when writ large the industry says we need secrecy. We need private negotiations and leverage to effectuate our price. While I'm sure that there are those in the commodity industry that say it would be great if we could have that too and potentially, eke out some better deals for us along the ways, I think we perhaps perceive that in the aggregate, it would be better deals for some than others, and we want a more uniform experience to that commodity than perhaps the decisions we've decided are what we want in the drug pricing space.
But do you feel that, I mean, you've been obviously looking at this for a very long time in your background, your history. To me, it's a very, I don't even know whether upper payment limits is the answer or 340B. I mean, I think there's a lot of different tools in the toolbox, but it all boils down to simplicity. And I don't know how we get to simplicity unless Congress, which has its own issues, is willing to get everyone around the table at the same time and kind of lock the door, because everyone is looking for their own slice. And I don't know how you make this a better process than to eliminate some of this pricing structure. Instead of 14, maybe get down to 2 or 3, right?
I would say that, some of that is just the what is possible and what's not. Like, again, if you were king of Maryland for a day, you couldn't necessarily change the Medicaid drug rebate program because that's a federal program, right? So there's going to be limitations of what is and isn't possible depending upon where you fall in the system and what perhaps trade-offs were willing to be made to get a different one. I think that writ large, we have, decided that when we talk about drugs, we tend to talk about wanting innovative, the latest and greatest therapies. Sometimes other countries talk about drugs in different ways. Australia says, in their healthcare law, the first thing that they're focused on is access.
Right.
You're focused on access, you want good transparency and, price that you can operate a market on around that. So there's always going to be trade-offs. There's no panacea. I assure you that if there was a universal win-win-win, there's enough smart people, smarter than I, that are interested that would be advocated and, effectuated. I think it's what are you doing with the tools that you have?
Great. Thank you.
Hey.
Mr. Lipsy?
Yeah, I just want to thank Van for the question, actually. I come out of mostly consumer packaged goods, stuff you find in the supermarket. And you have set prices based on quantity discounts. You've got published discounts for certain performance things that are done. They're open to everyone. Yes, you have wholesalers in the process. Yes, they have certain markup for selling to smaller operations, but the level of price variation in my experience from the worlds I have been involved in versus what goes on in pharmaceutical pricing is, I mean, it's like two different universe.
Yeah, again, I think that what we saw, or hopefully what I presented, speaks to that, right? If you look at this proposal, right, not only do you have a current incumbent, but that incumbent is rebidding on the business and doing so in a way that is providing a pretty significant, in my opinion, step up for just renewing it. But the question becomes, if that was the newer, like, was there really a 4% gap in generic pricing, or was I perhaps not experiencing your best pricing today? There can be a variety of reasons for that. I think your question speaks to a little bit, but the question is that, should that variety be such that there's a 5% difference, a 10% difference? What sort of variability is actually tolerated?
Yeah, just on a personal basis, I'm on one maintenance med. It's a generic. I'm on Part D plan. The Part D plan is $2.50 for the year. The generic drug is free. I'm going, somebody's making money someplace, but I haven't figured out where in that process yet. And the pharmacy I use happens to be, through Giant Food, and they run their own pharmacy program, and I'm sure they've got their own PBM, and they have their own version of a GoodRx card, which actually they don't promote. But if you talk to the pharmacist, suddenly they can come up with discounts that are better than GoodRx. And I'm going, there's something operating behind the scenes here that nobody can, at least I haven't been able to figure out. And I've been part of this commission, the stakeholder council now for what, well longer than the anticipated period of time. And my head still spins. So.
Great, thank you, Mr. Lipsy. Not seeing any other questions. Mr. Link, if you wanted to move on to the conclusion.
Sure. So just, I think what I would try to convey to this group is that, in essence, a lot of what I think a good starting point in conversations around drug pricing is a deliberate acknowledgement of what drug pricing should accomplish. What do you want drug pricing to do? There are those that take data and publish, if you look at what is expended on healthcare, on drugs, whatever have you, and what we seem to be getting from that investment, there are certain reasons to question our ROI. Everyone, I think, knows that the United States spends more on healthcare relative to the rest of the world and is not necessarily receiving the returns on investment as measured by things like life expectancy or quality measures or whatever have you. Many attribute, the difference in that experience to the simple fact that the United States has very high prices for things. It's the price is stupid is a famous article in our drug pricing world and our healthcare space about when you think about what the United States pays relative to everyone else, we can certainly see that it's higher in the aggregate. But some of the context that's missed when we look at that is that the United States does not have a oneness in price experience. Just segmenting drugs based upon brand and generic, we can see that while yes, the United States pays significantly more for brand drugs, generic drugs in general are significantly cheaper than in the rest of the world. 9 out of 10 people take generic drugs relative to brand, so the value accruing is not 100% where the high price and the low price or whatever is totally disaligned. We can see instances where the prices are low. We know within the various drug prices for the United States, the same drug can perceive to be very low in price and very high in price depending upon what we're asking of the drug price. We see with things like the 340B program, the drug being very cheap for providers to acquire if they have access to that program, and potentially a great deal more expensive if they don't. When a generic drug's price looks like a brand's price, we saw with our AWP scatter plots, a drug can perceive to be a lot more expensive than it really is, even though it is effectively the same drug, the same service being offered. In essence, we have boiled down drug pricing to a problem that we think we understand how to control. It is the unit cost. It is the mix of products. It is how much we're using and where. But there is a potential problem in a consolidated or integrated healthcare space where these same tools that can be used to drive things down can also be used to drive cost up. And if the various parties are not aligned to have incentives to push and pull on each other, it can become very easy for the system to take these tools and align them to just make more money. And so I am very grateful for the opportunity to present to you all. I appreciate the huge time commitment that you gave me, and I hope it was of benefit.
Great. Well, thank you, Dr. Link. Any final questions from the Stakeholder Council? With that, Dr. Link, we'll let you know if any other questions do come in. And for everyone, this will be posted, and we hope that this will be a reference that we'll continue to go back to and use. So Dr. Link, thank you so much for your time. This was amazing.
Dr. Link, I'd like to thank you as well. It was a wonderful presentation.
Great.
So,
And then Chair Diane, if you, okay, yeah.
So I'm sure everyone is anxious to get on to dinner. Thank you all for your time and feedback today. This was an excellent meeting. The next PDASC meeting will take place on Monday, June 23rd, 2025 at 2:00 p.m. Do I have a motion to adjourn?
So move. Jim Gutman.
And a second?
I'll second it.
Thank you. The meeting is adjourned at 4:48 p.m. Thank you and have a good week.
Thank you.